Good afternoon, everybody. Welcome to this session, which is organized by the European Society for Cornea and Ocular Surface Disease Specialists, EUCORNEA. We're grateful to the All India Ophthalmology Society and the Asia Pacific Academy of Ophthalmology for giving us this opportunity to present a potpourri from Europe. So it's not a themed, but the only thing connecting all the talks is that it's cornea. So we have different subjects we're going to be covering. It's my pleasure to introduce Nicholas Alexander, who's going to first talk to us about management approaches to keratoconus.
So thank you, Professor Dua. It's really an honor to be here with all of you representing EUCORNEA. So those are my conflicts of interest, and I'm just starting. So I'm not starting with the debate of what's a keratoconus and what's not. Just tell you that what we rely a lot on the posterior surface, and we publish the data from our database some years ago, where we found that it was very useful for us, the toric ellipsoid with fixed eccentricity. We had great sensibility, and then so that's what we use for screening the patients. No? So the first message is every keratoconus need to be looked for their ocular surface, because we know eye rubbing it's a problem. So anything on the ocular surface needs to be addressed to improve the prognosis and the symptoms of these patients. So we know we publish they have changes similar to dry eye patients in some characteristics. There are other groups that publish the increase in inflammatory cytokines and MMP9, and even the reductions with cyclosporine in those molecules, and also they showed an example of a patient improving the keratoconus after a treatment with cyclosporine. So remember, the first step of the algorithm is to treat ocular inflammation if there's any. Then, in my opinion, we have to decide if the keratoconus is progressing or not. And I haven't entered in this talk the debate of how should we define progression, but we can discuss it later if you want. So in theory, we know that the longer the crosslink, the more oxygen and the more cross-linking effect you will have. And it also happens in vitro, and the effect in patients, also we can see that in patients, that the longer the cross-linking, the more effect we have. So we know cross-linking is effective in general, and we know it's effective in children, even in the long term. But we know that the main risk factor for repeating crosslink is age. So younger patients tend to need more crosslinking done more times. And we know that adults and pediatric patients do not respond to accelerated crosslinking in the same way. That survival curve is after 9 milliwatts, 10 millimeters protocol. Also, in other studies, they found that non-accelerated crosslink had better results. With better results, I mean less progression, both in terms of visual acuity losing and in terms of applanation. So that's we decided to change our protocol according to the age of the patients. So below 18 years, we will perform the Dresden protocol. Between 18 and 30 years, we will perform a 15-minute protocol, and over 30 years old, we will go with the 9 milliwatts, 10 minutes protocol. We have just reviewed our data, and you can see the three groups are similar, but of course the age is different in every group. And also the children had bigger astigmatism, but that's how our cohort went. In total, we have really good results, what you would expect. We had applanation, improving on visual acuity, and at the bottom there were not many patients losing vision. So there are like one patient losing 4 lines, another patient losing 3, and 2 patients losing 2 lines. That's from 123 eyes, so not bad. There was no difference between groups when we are talking about aplanation, astigmatism, or changes in visual acuity. And there were 3 progressions in the 123 eyes. So that's just 2%. The first happened in the Dresden group, the children, and this one needed a repeated crosslink, even if we have performed a Dresden protocol before. In the second group, there was just 1 progression, and that patient did not underwent second crosslinking because of working problem. They wouldn't allow him to lose days at work, but then we found that 3.5 years after, there is no further progression. So it stabilized like 1 year after the cross-linking. Even if during that year it was progressing, then there was no more progression. And in the third group, we had a change of 1 diopter in the Kmax in 1 patient, and we decided not to cross-link, and the patient remained stable 3 years after. If there are thin corneas, what we will do is the sub-100 nomogram, so you can go to the paper and look the pachymetry of your patient, and then choose the time you're doing the 3 milliwatts irradiation, and they've shown reasonable stability for this kind of patients. When we have stopped progression, we have to decide how to improve optics. So besides spectacles and contact lens, which are great, now everyone is managing most of the patients with scleral lenses, but if it's not working, or if we need something else, we could do phakic IOLs in stable cones with good results, and the good thing is that we can combine that with other procedures. If the patient have cataract, we can perform the cataract surgery. We know now we are using the same that in the paper I'm showing, the Barrett 2K, and it's true we choose the target according to the stage of the more severe the keratoconus, the more myopic our target will become. But I have a question for you, because we know astigmatism and coma cancel each other in a way. When we're targeting for emetropia, we're not choosing the best focus for the patient, and we know that. That's a real example. That's a paraxial refraction of the patient, and that will be the best focus. And the patient will be seen differently if we choose emetropia or we choose the best focus. But that's a thing for the vet, and we are thinking how to improve that. Of course, you can try to change the shape of the cornea, and so you can do a PRK, topographic guided PRK with cross-linking, and there are many ways of doing so. Now I have just learned that there is also the Moscow protocol in the other, so, but you can, the protocols are quite similar, and let's say it works, but I wouldn't say you can prove any differences between the protocols. No. I'm a big fan of intracorneal ring segments. What we did some years ago was to see which the changes induced by each combination, and in the axis of the segment, and how the aberrometry will change, and the diameter or the radius of curvature of each axis, and we published that. And the main take-home message is the closer you are to the center, the more effect you will have. Same goes for applanation, but also for aberrations. And for example, you can target astigmatism without changing the aberrations if you choose a symmetrical combination with short segments, and I could enter in the details, but I have to speed up. So there's a recent meta-analysis with KERS, and I would say the meta-analysis says, and I would agree, that the effects are comparable with intracorneal ring segments. So in my hands, it would be good for thinner corneas, and also in those patients where you had trouble with the intracorneal ring segments. I think KERS can be very useful there, and if the nomograms become better, maybe it will expand, but at this point in my hands, intracorneal ring segments are more predictable, if we can talk about predictability here. Of course, we have also the corneal tissue adhesion keratoplasty now, so you can add just the bone man layer, but the dissection will be difficult. It has been you will indicate that where no cross-linking, there is no cross-linking indication, so if you perform a pocket in those corneas, you may risk anhidrosis. They say the onlay has less risks. I have no experience, and the published data is just short case series. So I couldn't talk about. I cannot talk about percentages or visual acuity in general. Same goes for intralamellar keratoplasty, though this seems more promising, but we have just case series, and we know that the lenticle can be customized with laser. Let's see where it goes. At this point in my armamentum, it's not included because I don't like to put anything in the visual axis if I can avoid it. But that's my reason at this point. But yeah, if we have not been successful with anything else, DALK has very good results in these patients. You all know that, and I'm not going to enter in the specifics of the techniques, but we could discuss it after. So that will be all, and we will be meeting again, some of us in Prague. I hope someone in the audience wants to join us there. Yeah, thank you very much.
Well, thank you, Nicholas, for that comprehensive overview of management approach to keratoconus. Now, Bruce Allen is actually speaking at another session, so he will join later. So I'm going to speak before him, and then he'll come.
So Professor Duat needs no presentation, so let's hear him.
So all of us know that DALK is now the gold standard for patients who have a normal endothelium yet need keratoplasty for whatever reason, scars or ectasias. When we do DALK operation, there are three main techniques: air injection, viscodissection, or a mechanical or manual approach. All of them attempt to reach the deepest plane, as deep as you can, to the pre-Descemet's layer or the Descemet's membrane. And a lot of information on the techniques and this science and surgery are in these two references. The first one is a book chapter, and the other is in Progress in Retina and Eye Research, which is free to download from the internet. Now let's look at DALK by air injection. What happens when you inject air? If you look at it minutely, and these are human eye bank eyes, you will find that air moves from the center in radial tracks towards the limbus. And this can be in a compact cornea in the form of fine, like cracks in a glass line, or more diffuse. Once it reaches the limbus, and here you can see one track, it then goes clockwise and anti-clockwise to make a complete circle. And when it forms that circle, which is quite unique, it tells us that the microanatomy of the periphery of the cornea is different to that of the center, because this is a very consistent manner of spread of air. And if you do a section across that, what you find that this part of the periphery is more aerated than the center, and you see all those bubbles accumulating at the periphery. That's the part of the cornea, 1.5 to 2 millimeters, where it becomes prolate and is also the thicker part of the cornea. Then the air moves centrally from here, collects in the form of tiny bubbles, which coalesce to form a central bubble, which then lifts up to form a large bubble which extends between 8 to 9 millimeters but doesn't go beyond. Sometimes a thinner bubble forms at the periphery and then extends across the entire surface of the cornea, and occasionally you get the two together, a thin one at the periphery and the large central one. The bigger one, this one is called the type 1, the thinner one is called the type 2, and this is the mixed, where you've got a complete lift of the desmids and of the predesmids layer over here. This, as you can see, is the histology of that, the air and the predesmids layer from which the endothelium has been desmos membrane has been removed. So that's a thin layer that we're talking of, which is usually exposed in the dark operation by air injection. Now, if you take away the desmos membrane and you make the eye upside down, the cornea that is, inflate it and do phototherapeutic keratectomy for about 20 microns and then inject air, you can never get a type 1 bubble. So it's telling us that that layer is important for that bubble to form, and it is quite unique, and it's not a random separation of the stroma. Now, this is what happens in the human eye. You see that circular movement is coalescing in the center, lifts to form the type 1 bubble. And when we do DALK, as Nicholas just showed you, you're injecting air. Now, because there's a cut in the cornea, so the air may not go to the periphery, but you get that bubble with a white ring. You take the top off, you puncture the air, you puncture the bubble, release the air, cut it into 4 quadrants, and you take that and put the new cornea. So what you've exposed there is the anterior surface of the predesmids layer. Now, this layer is quite tough. You have to push the pressure up to 700 millimeters of mercury to burst it. Now, that's very reassuring, because during DALK you can do a lot of maneuvers and preserve that layer and not damage it. And even if you get a minor perforation, you can carry on with the DALK and complete it successfully. And because of that toughness, you can also do the whole cataract operation with implant under the predesmids layer. When you're doing a DALK in a scarred cornea and you cannot see through to do the cataract, people have done this triple procedure. We published on this, called it the DALK triple procedure. You can do, but you cannot attempt this when you get the thin type 2 bubble with the desmids membrane only. It's only the predesmids layer that will allow you to do that and complete the procedure, both cataract and the DALK. Now, what happens in other occasions, you'll see here that circular movement, and then the bubble starts at the periphery and goes across the entire posterior surface. So this is where air is accumulating anterior to the desmids membrane, and this is the type 2 bubble. It goes all the way to the periphery, and it's important to know, because in the human eye, when you're doing this, you'll see you get a clear bubble margin with no white, and it goes all the way to the periphery. Now, if you're going to do paracentesis in these eyes, you're very likely to rupture the desmids. So you have to be very careful not to do a paracentesis unless you've released the air and everything has moved anteriorly, so that there's space for your paracentesis knife to go in without rupturing the bubble. And this is what happens if you're not aware, and this has happened when we were not aware of this kind of bubble. Now, the first one is from Kana Ramesh. Kindly loaned me this video, and you can see what's happening here is that the cornea has been put, he moves the eye to one side, and just that pressure allows the desmids to burst. Now, tells us that this type 2 bubble is very weak, and one should not undertake too many maneuvers when you're doing that. And then this one over here, you will see a nice bubble has been attained. I'm trying to trim the edge, and look, the whole thing goes. This is what happened with the desmids membrane. It never happens with the type 1 bubble with the predesmids layers there. But not only has it burst 360 degrees, and you can take the whole desmids membrane off. So very important that we constantly lower the pressure through the paracentis by releasing aqueous and keep the desmids membrane flaccid, so that you can successfully complete the operation. Sometimes if your trephination does not reach the bubble does not reach the edge of the trephination, you will see strands extending between the posterior stroma and the anterior surface of the predesmids layer, which have to be cut or teased off. this will only happen with a type 1 bubble, which fortunately is 85% of the times. And it also helps you, these strands helps you distinguish between a type 1 and a type 2. When you see a rough surface like that, you know you've got a type 1 bubble. If you see a very smooth surface like that, it's a type 2 bubble. This is where you have to take all those precautions. And these are just some scanning and transmission EM pictures to show you those strands extending between the bubble wall and the stroma. This is mixed bubbles where you get a type 1 component centrally and a type 2 on the periphery. And this is one example, a video lent to me by Tariq Katamish, where clinically how this type 2 will look. And you can see the top has been taken off, but there's another bubble underneath. And as you release that, you can see the desmus membrane. So there were 2 bubbles over here. You can peel off the desmus membrane entirely from a type 1 bubble like this. It doesn't burst, telling you that the predesmus layer is impervious to air. But when you do histology of the desmus peeled from a type 1, a type 2, or a mixed bubble, it's completely intact. There's never a split between the banded and non-banded zones, which was the explanation provided for a mixed bubble. This predesmus layer continues as the trabecular meshwork, and there are fenestrations at the periphery like so, and these fenestrations are what allows air to escape and cause the type 2 bubble to start at the periphery. You can see if the desmus is attached there, air will escape from the fenestrations, collect anterior to the desmus membrane. Sorry, here in this case the air will go in the anterior chamber in a type 1 bubble. But if the desmus is attached here, it will collect anterior to the desmus membrane, cause a type 2 bubble. So it explains why sometimes you get one type of bubble and sometimes you get the other. What about viscodissection? When you do viscodissection, just 2 slides to tell you, the depth of the needle is very important, or the cannula. If you are in the anterior stroma, you get a diffuse spread without a bubble forming. If you are in mid-stroma, you can get either a diffuse spread or an intrastromal big bubble. It just rips apart the stroma and you get what looks exactly like a type 1 bubble, but you've got a variable amount of stroma at the bottom. And you have to be wary of that, and only OCT will tell you, as you see over here. If you are really deep, then you can get a type 1 bubble, but it's extremely unlikely to get a type 2 bubble, which means viscoelastic accumulating anterior to the desmus membrane with viscodissection. So you will get a type 1 or an intrastromal bubble, and you can see the amount of stroma left behind. On the table, it may look like a type 1, and you may end up with a lot of thickness and irregularity in the depth. What about the third technique, the manual technique? When you don't get any kind of bubble, then things can happen which can give you a little extra help, like you see over here. Air went straight into the anterior chamber, so you come out, inject air at another point, you get a small intrastromal bubble, so that's very good. You release the air in that small bubble, and then mechanically with a spatula, you can dissect all the way around like a type 1 bubble and get exactly the same result. This is another approach which Rishi Swaroop sent this video to me. If you're deep enough, visco bubble was tried, it didn't work. You can actually physically peel off the entire stroma from the predesmus layer, and you can create what was the equivalent of a type 1 bubble end result. So there are other mechanical ways which are not, which are few of them which I can't cover all in this talk, but mechanical separation, exploiting that cleavage plane is possible if you don't get any type of bubble, and you can more often than not end up with successful type 1 equivalent of the DALC. So in summary, knowledge of the posterior corneal anatomy is key to understanding corneal surgery, and we know now corneal pathology, and the predesmus layer, desmus membrane, posterior corneal stromal relationships are important in lamellar keratoplasty, whether it's DALC or endothelial keratoplasty, and it's helped in planning, designing, developing surgery. So all this information will help you understand more of what you see during the operation and help you to improvise and change your technique to adapt to the situation as it develops during surgery. Thank you.
Okay, now it's the time. We've changed the turn, but now is the time of Dr. Bruce Allen, an amazing corneal surgeon from Moorfields. Thank you, Bruce.
Great, thank you very much. I'm so sorry about the timetabling disruption here. So I'm going to, when the talk comes up on the screen, follow Harminder with some interesting use cases for endothelial keratoplasty. So rather than talking about DMEC technique generally, we're going to just talk about some use cases for endothelial keratoplasty which have found a place in our practice and may be useful for yours too. So we're going to start out with macro perforations. So the conventional approach to a macro perforation surgically is to do a lamellar dissection. Is there a pointer here? Is there some kind of, or can I point with the mouse?
It will work anyway.
Oh, there we are. Okay. So you normally have to take your lamellar bed down to a depth that's deep enough to take a full thickness piece of donor tissue, which is hard work, and then you have to put the cornea over the top of it, map out the size of the defect by dotting through the cornea there, mount the cornea on an artificial anterior chamber, cut that out, sew it in. That's 2.5 hours work quite often, and you end up with quite a lot of irregular astigmatism. So we were looking for a better way in these kind of, particularly the quiet post-glue medically treated perforations. So I'm just going to stop this video here because we seem to have jumped forwards. And so we were looking for a way of dealing with this without such a laborious surgical approach. So we were thinking of using endothelial keratoplasty as a plug to plug ab interno. And this is a video that my colleague Alfonso Vasquez Perez, a super surgeon who was working with me as a fellow at the time, has put together, and he's taken this forward really nicely. So we mark the DSEC donor out. Here we are in the wet lab, trying out different bursting pressures with different sizes of experimental perforation. You can move this little patch quite easily with a needle over Provisc in the chamber there. And how do we do with a bigger perforation? Look what happens here, and it herniates through. So what are we going to do about that? Well, a mattress suture works really well to give it that extra support that it needs. And then you can close even quite a large perforation with a DMEC patch posteriorly. It's quite an easy thing to do technically on the table, and well worth trying in advance of doing a conventional banana graft or something like that, particularly for an off-axis perforation. So here's the first case we tried it in. It's just off-axis, this perforation. And rather than doing just a straightforward PK through the center, he had a normal endothelium, normal cornea elsewhere. We tried the patch. And you can see there, once we got air introduced, the air tamponades it in place. We can then layer up with fibrin glue and amniotic membrane, and finishing off with basement membrane side down, amniotic membrane there just to encourage epithelialization, and removing the viscoelastic and the air through the side there. And there it is 3 days later, and here it is, I think that's 6 weeks down the track. And the encouraging thing is this patient is 6'6" unaided, unlike a PK, for example. It's rather a thick posterior donor there, posterior plug. So we then went down to a thinner plug, and this is a case of a peripheral melt. And that's freeing up the iris adhesions there, and then preparing the donor. And we usually go about 1 millimeter larger than the perforation all round, and then pushing this donor through the perforation there. That's Alfonso's rather nice variation, and a bit of air in the chamber, and then some fibrin glue and some amniotic membrane to layer up there, and then a bit of amniotic membrane over the top, basement membrane down to finish off to encourage epithelialization. And again, in a eye like this, I think this might have been a Stevens-Johnson case, not a good prospect for a penetrating graft at all. You're just seeking to preserve globe integrity. Then it's a really nice variation. I'll skip this on a bit because I want to show you the mattress suture in the third case we've got. I think that we've got that here. There we are, thinner graft. And I think I can fast forward here. I'm going to try. I can't. Okay. So here's a larger perforation, but you can see the mattress suture going in over there. And that stops the donor just herniating straight back through the perforation when you put the air bubble in the chamber. So I'll leave it there because I want to move on and show you a couple of other things. But that's a nice variation on doing a large tectonic graft in cases where either you're not seeking to preserve vision, you're just trying to preserve globe integrity, or an off-axis perforation in an otherwise fairly normal cornea like the first case we saw. Something that's going to go well in tandem with that, I think, is newer regenerative bioglues, and this is a collaboration with May Griffith in Montreal. We've had some really promising results in mini pigs. You see normal cornea along the top pane here, and the lamellar defect that's been filled with the gel, a bit like using a dental filler, and then you get cellular regeneration into that framework and nerve regeneration as well, and a normal epithelium too. That's not too far away from clinical trials now, I hope. So how about another use case? This is posterior stromal opacity. Remember, the original iteration of endothelial keratoplasty was DLEC, where we removed the posterior stroma as well as the donor. So you can use the femtosecond laser to make a nice ring cut there, and that deals with the most technically difficult part of that operation. Femtosecond lasers don't work well in the posterior stroma for a lamellar cut, by the way. They don't produce a regular or a good clean cut. So do a lamellar dissection first, take the patient upstairs to the femtosecond laser, do the ring cut, and then it's a beautifully easy operation technically to do a DLEC. And so here's the side, a compare and contrast for that rather unusual copper deposition syndrome there, hypergammaglobulinemia. Here's the cornea before the surgery. On the left, you've got what happened when we did a DSEC, and with that thought, well, there's an improvement. We can just see the pupil here, but it's not as clear as we would like. But look at the difference when we did a DLEC there in the other eye. So a nice variation. Also useful if you get a bad posterior lamella with a lamellar graft. You can do the ring cut with the excimer laser, peel out the scarred posterior lamella, and drop in a little DMEC or a DSEC there, and that works really well. How about the last little corner that I want to show you, that if you may have a case like this that's aphakic, a unicameral eye, and you want to do a DMEC because it's a bit easier in terms of avoidance of rejection than a DSEC and a safety net suture. So that's, we don't want to drop it in the back of the eye. And so this safety net suture technique here is a nice variation. We'll show you that just now. The main thing to say about that is it has to be an odd number of passes backwards and forwards across the anterior chamber to create this safety net. Otherwise, you don't finish up where you started. And that's with a straight tenoproline there, back and forth, an odd number of passes in both directions, and then you should finish where you started. We've learned that it's best if you don't make your incisions until after you've done this, just a very small incision to keep filling the chamber through, and leave the other incisions until afterwards. This is very difficult in a soft eye. And so we're going backwards and forwards there across the chamber to create that safety net pattern. And finishing up where we started. And this creates a really nice, shallow, pseudo anterior chamber, and makes it very easy to unfold the donor subsequently. And again, it's a technique that looks more technically difficult than it really is. A nice variation, if you get a deeper set eye, is to bend the needle. And that was something that was described by Samuel Maskett when he talked about using a similar technique to support intraocular lenses during surgery. And so we should finish up with this last pass, which you're going to see at the moment, just where we started, ready to tie it off. And then you have your safety net, and you're ready to make your incisions. How are we doing for time? We must be almost over, yeah? 2 minutes more. Oh, okay, better than I thought. All right, so we're just going to finish off where we started and tie off. And as I say, what we learned is that if we do this after we've made, before we've made our incisions, it's much easier. You don't have the eye softening all the time with leakage through the incisions when you're passing the sutures. So we just do one small one, this little one on the sides to fill up the eye to a firm pressure, and it's quick and easy to do that with a Simcoe, by the way, or you can use an AC maintainer if you want to. And then your incisions, just make sure you stay anterior to your safety net and try not to cut the suture. Easy enough to do though. And then you have to do the rhexis over air in a unicameral eye. And you can see the suture pretty clearly there. And so the rhexis is done over air. Always difficult to contain the air bubble in the AC, so again you can use an AC maintainer and air infusion if you want to. But this is much easier than we thought it was going to be. Once you have the graft laid out, just inject slowly. And then the chamber is shallowed by the suture, and it's quite easy to open up the graft. And there you can just follow with a little mini bubble underneath that, and use the little sweeps with the Simcoe just to center the graft over the mini bubble. That's a technique that Frank Price showed me. Really nice addition to your EK technique if you're not already using that. And then fill up to a good pressure with the eye with the fluid, then you tend to get the bubble behaving better in the chamber when you inject it if you fill the eye up to a pressure first. And then it's easy to remove this suture. And most DMEC detachments are partial, even if you get a detachment, so you can remove the suture at the operation. You don't have to leave it in, but you can if you want to. And so there's a case, and there are a few more. But I've just come from an innovation session on cell therapies in endothelial keratoplasty, and this is great. I mean, you can all do this now. It's one of these things you can just see the video and you can do it right away. But I don't think we're going to be doing this for very long in these kind of eyes, because what looks really good to me is cell therapy without passage. We were talking about this last night, weren't we, Nicholas? And I think that's going to be the way to go, is just taking a cornea, taking the cells from it, injecting them, posturing the patient. And in these kind of technically difficult cases, like the unicameral eyes, the eyes with an irregular posterior surface, I think it's going to change everything. So for now, though, this is useful. Thanks. So I'll leave it there. Oh, last word, though. I want to advertise our little session in Prague. So if you have a free spot in your summer, I really hope you're going to join Harminder and Nicholas and Jesper and Frank and all of us over in Prague for a nice meeting there. Bye. Bye.
Right. Like to invite Dr. Dalia Said, who's a consultant colleague of mine in Nottingham, and she's going to talk about pterygium surgery, how to prevent recurrence and how to treat recurrence.
Oh. Can I go back? Can I go back first? Just are you going to open it? Thank you very much. It's not on yet. He's putting. No, I think you just need to go back.
Go back to the beginning.
Go back. Start from the beginning, please. Yeah, thank you. So I'm going to speak to you about how to prevent recurrence and how to treat recurrence. We all know that recurrence is the most common complications of pterygium surgery, and pretty much almost 87% will happen in the first year. There are definitely risk factors such as young age, black race, patients having dry eyes. If you have a fleshy pterygium, the surgical techniques also can affect the recurrence, especially if you leave a bare sclera or there is increased inflammation, which are culprits for recurrence. Other factors have been implicated, such as abnormalities in the P53 gene, which is a tumor suppressor gene responsible for promotion, epithelializations, and apoptosis. Also, some people have said that expression of VEGF receptors also is implicated, and even some viruses have been implicated in pterygium recurrence. So we have really few rules to put down to prevent or reduce recurrence. First, know when to operate. So if you have a patient like this with a very thin not fleshy pterygium, with especially if there is a stalker line where there is hemocydin deposits along the front surface of the pterygium, then you know that this is not a progressive pterygium. So do not operate in cases like this unless the patient really doesn't like it for cosmetic purpose. Again, there is the cousin of pterygium, which is called diffuse keratoconjunctival proliferation, where you get a limbal roll and then you can get fibrovascular proliferation on top, which takes a very, very long time to progress. So these cases you really don't need to operate on, especially if you have a central island of healthy corneal epithelium with good visual acuity. This it shows collagenous degeneration on top of the elastotic degeneration when you take it out, and it is a very, very slowly growing and can be stable for many years. If you see fuchs flecks, which are little flecks that you can see here in front of the head of the pterygium, so these are potentially active basal epithelial cells and potentially have been implicated with progression of pterygium. So really there are many, many classifications for pterygium. There is no really verdict on which one to use, but generally a fleshy pterygium which is also vascular, highly vascular like this one, 10-3, this one is one to remove. But you can have still another fleshy pterygium like the lower picture, but this is not an active pterygium, it's not vascularized, so you don't really need to remove that one except for cosmetic reason or if it's affecting vision. And then the vertical height also have been implicated, but you can have same vertical height with one which is very fleshy and progressive, and the same vertical height with one which is not active and does not need to be removed. So you have to really use your common sense which ones to operate on which ones you don't. But if it's affecting visual acuity, it's progressive, causing astigmatism, restriction of movement, and even cosmetic, then it is an indication for removal. Then the second rule is the actual surgical techniques. Avoid surgical techniques which are known to have a higher incidence of recurrence. You do not want to leave a bare sclera at all without any epithelial cover, because that induces inflammation, and inflammation is a big culprit for recurrence. Obviously avoid all techniques such as beta irradiation, thiotepa, which are obsolete nowadays. The amniotic membrane has been used to cover the area of the defect after pterygium surgery, and although it can work, but it is still associated with high rate of recurrence. So if you don't have enough conjunctiva to cover the area of the defect and you want to use an amniotic membrane, you can do that, but take a small area of autoconjunctival graft and stick it on the amnion. Then it's a source of epithelium and you don't have a large area where the amnion is bare, and this has been shown to reduce the incidence of recurrence. This is an example of a patient which we used the amniotic membrane because the conjunctiva was stuck down after recurrence, but we had recurrence very, just a few weeks after, very soon. So that's why amniotic membrane on its own can be associated with recurrence. So it's been now the standard procedures to use conjunctival autograft in pterygium surgery, and we usually tend to use fibrin glue, and randomized studies have showed that using conjunctival autograft reduces the recurrence rate of about 16% in comparison to 42 if you're using an autoconj graft instead of the amniotic membrane. And even in recurrent pterygioms, if you again use an autoconj graft, then you can reduce the recurrence further. Now, in your surgical techniques, it is very good to do extensive resection of the pterygium tissue, and up to even the semilunar folds, and these have showed the much less recurrence rates. People have also used slit techniques with extensive removal. Not necessarily that the slit will affect the results, because actually you do have the stem cells available in all of the other quadrants which can cover this area, but the actual extensive removal of the pterygium tissues is the key in doing these surgeries. Adjuvants, anti-metabolites, so intraoperative MMC alkylating agents, or topical even anti-VEGFs have been used, and subconjunctival 5FU we use quite often, and I'll show you later. And even there have been reports of inhibition of fibrosis with rho kinase inhibitors. So we always use fibrin glue because it's easier, surgical time is less, and definitely less recurrence because there are no sutures, and the sutures are also culprit for inflammation. And people have also used autologous blood, and which is cheaper, but it is associated with more graft displacement. It is important when you're doing your autoconjunctival graft that the graft is very thin. Otherwise, if it's too thick, then you can get a Dellen effect and you can get more inflammation, which can promote recurrence, like in this case. Now, when you do an autoconjunctival graft, you will find that the graft will swell initially because of exudation, edema, and transudation of tissue, but then eventually it will all settle back. So this is 1 week after. Don't be worried if you see that quite edematous graft initially, because eventually it will just become very absorbed, and as soon as the vascularization happens between the autoconjunctival graft and the patient's tissue. The rule number 3 is really recognize conjunctival recurrence. So you really want to treat these recurrences at this stage when the recurrence is starting behind the autoconj graft or from the sides of the autoconj graft. You don't want to wait until you have a full recurrence to start treating these patients. So what we do, and it was given very good results with us, is inject subconjunctival 5-fluorouracil 0.1 or to 0.2 mils, 2.5 milligrams per mil, and repeat this weekly until you abort the recurrence. And this is a patient who had 5 recurrences, and then he had to have 10 injections of over 5 months and completely settled, as you can see here in the last. This is another patient with 5 times recurrence, and the 5th time was quite extensive removal of the pterygium and even reformation of the fornices. He had a tendency of keloid formation, you can see here, and this is the area where the autoconj graft was taken. But again, he had a recurrence, and we knew he will have a recurrence, so we were ready with repeated injection of 5-FU until the patient completely settled. And since then, his son came again with a recurrence, but then with 5-FU that was halted in place. So since then, we've done quite a few patients published, and since this publication, more patients have been done. We rarely have to operate on recurrent pterygium now if it's our own patients, because we recognize conjunctival recurrence early, and we start injecting them with 5-FU with excellent results. And even one other thing you can do if you have a very fleshy pterygium, you can actually inject the primary pterygium with 5-FU together with Avastin or just 5-FU to reduce the vascularity, to reduce the thickness of the pterygium, and that has been shown to be much better effect with the reduced VEGF and other factors of inflammation and promoting of epithelialization. And later, when we've taken these pterygium tissue out, we found that these patients had never had any recurrence. So this is just a video to show you the technique of excision of recurrent pterygium with, it's very important to do extensive dissection of the pterygium tissue from under the conjunctiva, and even sometimes it is scarred down to the muscle. So if it is scarred down to the muscle, you have to hook the muscle and make sure you remove all the fibrovascular tissue. Do not reach the fat, but make extensive excision, especially from the sides, because most of the recurrences usually come from the sides. And once you've done that, then we put MMC 0.04%, 5 minutes under the conjunctiva and 3 minutes on the sclera. Once you've done that, then you can wash profusely and then take your autoconjunctival graft and use it, glue it in place. This is the graft. As you need to make the graft as thin as possible, slightly bigger than the defect if you can, and move it to where you want, and then put the glue, the thick and the thin components, and put it in place, and then also glue the conjunctival graft to the patient's own conjunctiva, and you can even use the fibrin glue to glue the area where you've taken the conj graft off. The future is actually targeting the MMP genes and to reduce the pterygium occurrence. But up until then, we need to identify patients who are at risk of recurrence, avoid surgical techniques that are associated with high recurrence, extensive surgical dissection, use of adjuvant antimetabolites, excision with autoconj graft is the gold standard, but recognize and treat early conjunctival recurrence. Thank you.
Now is the time of Professor Jordal from Copenhagen. He's going to talk about corneal infections.
So, thank you very much for allowing us to speak here in India. I think there's quite a big difference between the types of microbial keratitis what we see around the world. I come from Denmark, a tiny small country in the northern part of Europe here. And in Europe, we mainly see the red dots here is the place where there have been incidence studies. The blue squares, that's where bacterial keratitis is predominant. While here in India, in Southeast Asia, it's mainly fungal keratitis. So I will talk mainly about bacterial keratitis. So if we look upon risk factors for bacterial keratitis, there's an old study here from John Dart, a casualty-based control study, and he found that contact lens wearers are 80 times more likely, and those with ocular trauma are 14 times more likely to develop an episode of microbial keratitis than non-contact lens wearers who has known predisposing factors. Later on, this has probably been reduced a bit, but Stapleton from Australia found that the unadjusted incidence rate of corneal infection is of the order of 5 to 10 times higher in contact lens wearers. So contact lenses, that is certainly a risk factor. What else do we see as risk factors? Various kinds of ocular surface disease. These are two terrible cases here, one with neuroprosthetic cornea, one with ocular cicatricial pemphigoid. But I think today we also see new risk factors for bacterial keratitis. That can be autokeratology in children. Children rarely develop bacterial keratitis, but we have seen cases with auto-K use in children and grown-ups where people have developed bacterial keratitis. Also after corneal cross-linking, you can see bacterial keratitis. So what do we see in Europe typically? Well, if you look upon the world here, bacteria, that is 92% of the microbial keratitis cases, Acanthamoeba, something like 3%, and fungi, something like 4 or 5%. So it is bacteria we see most. And what types of bacteria do we see? Well, Pseudomonas keratitis, this is many years ago in our clinic. 18 hours after symptom start, the patient was a contact lens user. She showed up on our university eye clinic, and it looked like Pseudomonas. She was put into treatment at once with relevant antimicrobial therapy, and then it went by after 2 days, 4 days, actually progressive worsening, then a tendency for improvement, but after 3 weeks she perforated, and we had to do a penetrating keratoplasty in her. So Pseudomonas is definitely still a significant cause of very severe keratitis. Gram-negative bacteria, they are associated typically with contact lens wear. We have Pseudomonas as a good example. We can also, with increasing incidence, see patients, elderly patients with ocular surface disease, with Moraxella species or Serratia marcescens, and I took this picture with a nice colonies of Serratia shown here. The gram-positive bacteria we see, they are typically associated with ocular surface disease, and that's well known: Staphylococcus aureus, pneumococci, and coagulase-negative Staphylococcus. We do see fungi also, and this is a very severe case we saw a few years ago. In the UK, they have made a bigger study here in 2021, where they tried to look on all the fungal keratitis cases they could get hold of, and it was dominated by Candida species, Fusarium species, Aspergillus species, and topical treatment included voriconazole, natamycin, amphotericin B, and tectonic keratoplasty was necessary in 25% of the cases, and 50% of these keratoplasts failed. Another study from the UK, fungal keratitis in London over 10 years, 2016, where they observed an increasing incidence of, let's see where the arrow goes, over years here from 1994 up to 2014, and increase in filamentary keratitis, and we have seen the same in Denmark. Then we have acanthamoeba as well. A nice picture. It's not so often you can really see perineural infiltrates. Also a study from the UK, very big, with 86,000 patients with microbial keratitis. Out of these, 5,600 had acanthamoeba keratitis, and it is a rare disease. I mean, you can assume that you will see approximately 2 eyes with acanthamoeba per healthcare unit center per year. They couldn't see a difference between continents with of patients with acanthamoeba keratitis, and the ratio of eyes with acanthamoeba to the total number of eyes with microbial keratitis was 1 to 2%. So it is a rare disease, but we see it. And I know Frank Larkin will tell more later today about this. And what do we do? Well, when patient shows up, we take samples directly on the plates. It's time consuming, and unfortunately still gives no clinical useful results in up to 50%. So many times we have to rely on our clinical observations and actually choose a very broad spectrum antibiotics. Same is the case with staining methods, where you rarely get a clear diagnosis. And why is this? Because obviously the patient has an infection with bacteria, and it can be related to prior antibiotic use. It can be difficult to grow organisms from small samples, and there can be challenges to immediate incubation of culture plates to optimize diagnostic yield. PCR is used routinely, but it's mainly, and you have various types of PCR, quantitative and multiplex, and we use it widely, and I think it's the same all over the world for acanthamoeba, because we have never been have any luck with our labs growing acanthamoeba. So we use PCR for the detection, and then for the various herpes viridae. One thing more, we use confocal microscopes in many clinics. Fungal keratitis, where you can see hyphae. Actually, that's typically what we use. We use it also in acanthamoeba keratitis, but it's more difficult, and you really have to have sort of those using the microscope should have quite some experience. And as it is a very rare disease, acanthamoeba keratitis, we never in even big university clinics in Denmark get this expertise, but we use it and try. What do we do? Well, antibiotic therapy, we have touched upon that. The first and second generation fluoroquinolones, that's ciprofloxacin and ofloxacin, has a good activity against gram-negative bacteria, reasonable activity against most gram-positive bacteria. It was used in the 1990s. Then third and fourth generation fluoroquinolones were introduced in the 2000s, still with a broader spectrum activity against gram-positive bacteria, but less effective against Pseudomonas. And some still use dual therapy, drops vancomycin for gram-positive, fluoroquinolone or aminoglycoside, for example, gentamicin for gram-negative cover. What about resistance? It's a problem in general with antibiotics. If we see here for the gram-negatives, fluoroquinolone is here, aminoglycosides and cephalosporin here. So it looks like fluoroquinolones is a good selection choice for gram-negative all over the world. although here in Asia it can be a problem. What about gram-positives? Fluoroquinolones still effective in most cases. Aminoglycosides also. Cephalosporin is about similar in the UK. So what do we do? And just a comment upon microbial resistance. I think, or people that knows more about this than I do, is that overuse, misuse, and the indiscriminate use of antibiotics in agriculture are thought to be the key drivers for antimicrobial resistance. So that was to consider. Antifungal therapy, natamycin is the only commercial available drug in Europe. It's not EMA approved, but you can get it. Otherwise, we have to rely on pharmacy prepared drops, amphotericin B and voriconazole. And topical anti-amoebal therapy, I'm sure Frank Larkin will talk more about that. Chlorhexidine, polyhexanide, and propamidine. And then the study recently published, there's a protocol there. So should you use steroids in microbial keratitis? There have been some meta-analysis, randomized studies. These groups summarized 4 studies and no found any important difference between topical corticosteroid or placebo for reduction in ulcer size, etc. So I think, at least that's our belief, that in general steroids should be withheld until the clinician is confident that it is unlikely that any visible pathogenic bacteria or if revitalization has occurred. And we never use it in fungal keratitis, and maybe on the long run it has a place in academia. Finally, just touch upon other treatment modalities. PAX-CXL, photoactive thrombophores, can be done. Aminda and Tuft and others have commented on this. It may be an additional option for bacterial keratitis refractory to medical therapy. We look forward to a large US study that is going to present their results this year. Finally, amniotic membrane, meta-analysis again from Ting, and just summarizing that amniotic membrane may serve as a useful adjuvant therapy improving corneal healing and visual outcome. Future, next generation sequencing, we have tried that. Today it does not work, it does not help us. Artificial and deep learning may help still, but still not routine practice. So, conclusion, keratitis in Europe, bacterial keratitis is most common. Filamentary and academia are rare but increasing. Ciprofloxacin is often preferred for first-time treatment. So with this, I just wish you a good meeting, and this is our hospital in Denmark. Thank you.
So now's the time to Dr. Miriam Barbani from Barcelona. Thank you, Miriam.
Well, thank you for your kind invitation. This talk will be on neurotrophic keratopathy and neuropathic pain. So first of all, let's remind that corneal nerves and the neurosensory loop driven by the trigeminal pathway play a major role in modulating the blink response, stimulating the production of tears, and also maintaining the neurotrophic balance of the ocular surface through reepithelialization. And this is all controlled by innervation, but also by endocrine, vascular, and immune system. So this is the ocular surface system. But when we have a mechanical or an inflammatory damage that is consistent on time, then we will alter the corneal nerve structure, and eventually this will lead to nerve degeneration. So the first nodules will cause a neurogenic inflammation, and there will be a reaction of the body that will be good because it will promote the reepithelialization. But if it keeps going, then we will have a neuropathic pain or a neurotrophic keratopathy. The neurotrophic keratopathy is in fact the degeneration of the corneal nerves that will provoke an unhealing corneal epithelial defect and eventually an ulcer. This will be mainly caused by infections such as herpes, but also it can be caused by chemical burns, extensive use of contact lenses, corneal surgeries, or neurosurgical injuries. And these kind of patients will be the ones that will come to our office with lots of stain on the surface but without pain. And this is because the corneal degeneration will cause a decreased vitality of the epithelial cells, and we will see at stage 1 a cloudy and irregular corneal epithelium that will lead to epithelial defects, and in more progressed cases to deep corneal ulcers with a stromal melting. So we will classify our patients on the MACIS classification. It is very important, first of all, to do a proper clinical history. Here we will focus on previous ocular diseases such as herpes, ocular surgeries, and the things that we've been talking about. And also we will take into account the systemic diseases such as diabetes or multiple sclerosis. Also, we will ask about neurologic conditions such as brain tumors, neurosurgery, and so on. Another thing, it will be important to make a thoughtful ocular examination. So we'll start from out to inside the eye. We will look to the eyelids, especially rule out lag of thalamus at night, and also blinking alterations. It will be important also to check the fundus of the eye, to check if there's scarring, allergies, or some other issues. As for the ocular surface, we'll check if we have lesions on the cornea that let us think about dystrophies or previous infections, and it is very useful to put a drop of fluorescein and green lissamine tintions to check the state of the surface. Of course, we will look to the iris to check if there are areas of atrophy that we'll think about of herpes infections, and very important also to check the fundus to check if we have a diabetic retinopathy or a papilledema that make us think of brain alterations. In these patients, it is also very important to check the dry eye with some tests. Especially in our practice, we use a smolarity test, which will be normally increased, a tear film stability test that will be decreased, and a test of Schirmer that will be normally decreased. But the main point to check here will be the corneal sensitivity. It can be really easy in our office just to check it with a cotton wisp test. And here we will find that there's a hyposensitivity of the cornea. There are other devices such as the Cochet-Bonnet aesthesiometer or the Brill's aesthesiometer that can be helpful as well to monitor the quantity of decrease. And also it is important to check it in the different quadrants to make a proper map of the corneal sensitivity. Of course, we will also use, if we have it in our clinic, a confocal microscopy, and here we'll be able to see a decreased corneal nerve density, a higher number of hyperreflective keratocytes, and a diminished epithelial and endothelial cell density. As for the treatment, first of all, we will stop toxic drops, avoid preservatives, start lubrication, and we will control the inflammation with steroids and also immunomodulators. And in some cases, we can think about punctal occlusion. But if we have MACI stage 2, then we will start with drugs to prevent stromal melting. We will start also blood-derived drops to promote reepithelization, and also we will try to protect the cornea from the outside through contact lenses or closure of the eyelids. In our practice, it is quite easy to start with topical insulin. It's cheap for the patient, but sometimes it's not enough. So in those patients, we will switch to blood derivatives such as autologous serum, PRGF, PRP, or umbilical cord blood serum. Also, it will be very important in some cases to use the amniotic membrane. We all know that it gives us a mechanical protection, also a release of growth factors, and a support for epithelial cell adhesion, and it can be put in many ways depending on our choice. And of course, we will try to protect the cornea with non-surgical approaches, such as, for example, Nictavic, which is a stitch that you can put, and it will prevent the patient from opening the eye with Botox or with classic tarsorrhaphy. But unfortunately, we will have patients that will progress to a stage 2, and in those cases, we will need other approaches such as corneal neurotization in case we have everything okay, but we have a problem of the sensitivity of the cornea. It can be direct or indirect, and the basis of this procedure is to recover the sensitivity of the cornea, and it works wonderfully. It takes some months to start giving results, but it's a good procedure now. But in some cases that are more progressed, or where we have problems with the eyelids and also limbal deficiency, we will need other procedures such as keratoprosthesis, transmucous type 1, or osteokeratoprosthesis done with tibial bone or teeth. In this case, here we present a case of a patient that had Steven-Johnson syndrome, and for many years did well with a PK because everything was stable, but there was a moment where she had a fungal keratitis, and we had many problems of reepithelialization. So first of all, we decided to stabilize the patient with a mucosal graft, and after some months, 2 months, to leave it to vascularize and stable, then we did a K-Pro type 1 transmucous procedure. Here you can see how we assemble the device with a cornea, and once we have prepared our device, then we will go back to the eye, we will lift up the mucosal graft, and we will proceed to put the K-Pro 1. Here we can see the last part of the video, where finally we will open the window, we will make a hole that will connect the outside and let the light enter. This procedure works really well in those cases that a type 1 without the mucosa won't work. And what about the neuropathic pain? Here we will have not a denervation, but an alteration of the nerves. As you know, the first reaction of our body will be to have a nociceptive pain, which is helpful because it will promote reepithelialization. But if we have our body creates microneuromas, then we will have a neuropathic pain, that which is a pain that is caused by a lesion or disease of the somatosensory nervous system. Depending on where we have the lesion, the first order or the second order, we will have a peripheral or a central sensitization. And of course, we have other patients that won't have a clear evidence of actual or threatened tissue damage causing the pain, but these patients will be named as nociplastic pain, and they are correlated with conditions such as fibromyalgia, migraine, complex regional pain syndrome, or irritable bowel syndrome. And they can be coexisting, so it's important to know that this happens. And this will be related with many etiologies, especially with general neurologic diseases such as small fiber neuropathies. And what they will feel, this continuous firing of corneal nerve receptors may result in a lower stimulatory threshold. So these patients will experience hyperalgesia and also allodynia, especially photophobia. And also they will tell you about feeling of a sensation of pressure, burning, tingling, and electric pain sometimes in the trigeminal nerve area. It will be important to talk with them and even use ocular pain questionnaires to check the status, because they will have a low quality of life, and sometimes they will tell you that they have also problems of insomnia, mood swings, tinnitus, vertigo, things that do not correlate to the typical face the symptoms that our other patients have. Here you have some examples that you can adapt of pain questionnaires. And here, what we will have as the corneal sensitivity is that we have an hypersensitivity to a low threshold. And here, the main test will be the propagine challenge test that will give us information about where we have the lesion, if it's in the first order or the second order. So if we have this patient that complains with a pain and we put a drop of anesthesia and the pain is no longer there, then it will be peripheral pain. But if you put anesthesia and he keeps complaining, then it will be a central pain, and this will need further approaches to the typical treatments that we give to the eye. In the confocal microscopy, we will have this image of microneuromas, which are terminal enlargements of subbasal corneal nerves. And as I said, the treatment will be mainly on treatments on the ocular surface, but here we will need a multidisciplinary approach, a unit control pain, where we will need an anesthesiologist, a physiotherapeuta, a psychologist, and a dietist to properly treat it. Here we will need some treatments such as gabapentin or duloxetine to control the central pain. Also, it can be helpful, the Prochera devices or the filter lenses to prevent the extreme light photosensitivity. We will advise to check the vitamin B levels, especially B1, B6, and B12. And in some cases, it can be useful to do periocular injections with anti-inflammatories or anesthesias. And also, we can find some devices like extranasal neurostimulation that can work in these patients, or the toxin Botox injection in some areas. In some cases, and if you have it at your hospital, you can try to give neurostimulation and neuromodulation through these techniques. And of course, we will try to make a complete lifestyle change. So remember that normally NK will be stain without pain, and neuropathic pain, pain without stain. Thank you very much.
Well, thank you, Miriam. So we've saved the best for the last. It's a pleasure to welcome our guest speaker for this afternoon, Frank Larkin, who's a colleague from UK, working as a consultant at the Moorfields Eye Hospital, will give us an update on acanthamoeba keratitis.
Thank you, Harminder. It's quite appropriate to have a presentation from Europe about this disease because we see lots of patients with acanthamoeba keratitis. In my hospital, we have seen at least 100 new patients every year since at least 2010. And most of those patients are generated in our own emergency department, so that they're not referrals. So we've got a lot of experience with this keratitis, to which Jesper has already alluded. This is a completely different pathogen of the cornea to everything else. It's very large and it's very complex. One of the acanthamoeba genomes was sequenced a long time ago, 12 years ago. How many genes does an acanthamoeba have? 15,500. A bacteria, 200. A virus, depending, 750, 800. Amoeba, 15,500. Human beings, how many genes? About 20,000. These pathogens have more in common with us than with all the other pathogens that affect the cornea. So they're complex, and I think that partly explains why treatment is difficult. Two forms of the organism, and this is key to the poor therapeutic response in some patients. The amoeba, in adverse environmental conditions, can adopt a double wall, which is highly resilient to physical things, temperature, shortage of food, and resistant and resilient in the context of therapeutics also. The association with contact lens wear is enormous. In Europe, not as common in India, common in North America. The vast majority of the patients we see in Europe are contact lens wearers, all types. And we know from separate studies in Bristol in the west of England, in London, and in the United States, that domestic tap water in sinks and in showers and baths is the most common source of amoeba in the patient's environment. This is work done. The date of the publication is 1990, 35 years ago. We discovered that tap water was a source of amoeba, and we're still having problems with this disease. Imaging and the developments in imaging of the cornea have been very helpful in diagnosis, in particular in vivo confocal microscopy. The typical clinical features are listed. Quite a lot of photophobia in common with all forms of keratitis, epithelial or stromal disease with different clinical pictures becoming evident with severity of disease and more advanced and progressive disease. The problem cases, the patients that do not get a good response to infection, are the patients in whom pain is very difficult to manage, and that's uncommon. The patients with scleritis or necrotizing corneal perforation, both uncommon, and the patients with posterior segment involvement, and that's very, very uncommon, such as the patient whose fundus is photographed on the bottom of the slide with attenuated vessels. This is a picture very like central retinal artery occlusion without the cherry red spot. Flatty orgy. These are unusual acanthamoeba patients, but they are exceptionally difficult to manage. And of course, in the context of retinitis, there is no prospect of restoring vision. Diagnosis, unlike what Professor Yortal said a few minutes ago, we value culture very much, and we do try to culture amoeba in all the suspected cases that we encounter. Having said that, in London, it's confocal microscopy and PCR that really establish the diagnosis in most of our patients. The great advantage of confocal microscopy diagnosis is that it is immediate. You can start treatment without delay, and this is one of only 2 infections of the cornea in which confocal microscopy is really helpful, the other being filamentous fungus infection. So you've got an immediate diagnosis. We always, in suspected cases, would advise taking a specimen of the cornea for PCR and taking a specimen of the cornea for culture. But we would start antiamoebic treatment directly once we see cysts on confocal microscopy. You can then await the laboratory results from the PCR and the culture. If a patient has a confocal microscopy diagnosis, negative PCR and negative culture, I would be very careful in an acanthamoeba diagnosis in that patient. So if the patient does not respond to anti-acanthamoeba treatment and you only have a confocal microscopy diagnosis, think about other causes of chronic stromal keratitis. And you know them all: viral disease, microsporidia, etc. There are many. Antiamoebic agents. This is the area where we need an update, and there is none. If you look at the dates of the publications here, the first antiamoebic was Broline, which I'll show on the next slide. Discovery, 1987. Polyhexanide, PHMB, 1992. Chlorhexidine, which is the same molecule, a shorter number of polymer units, 1995. There has been no progress in therapeutics for this blinding keratitis of note since those years. Nothing. So an update on acanthamoebic keratitis is, in that respect, a very short lecture. What do these drugs do? The biguanides cause lethal structural and intracellular damage to trophozoites. but also to cysts. And you must have an agent that is cysticidal for effective anti-acanthamoeba treatment. So that's vital. There are no reported cases of cyst resistance to polyhexanide or to chlorhexidine. There have been none. But we do not in all cases get the therapeutic response expected. So in Moorfields, we will typically start with a biguanide monotherapy, commenced very frequently for the first 2 days, hourly day and night, certainly hourly throughout the day, and reduce the frequency with a maintenance dose. Treated until the patient has a white eye and not taking steroid. So that's a question that commonly comes up: how long do you treat with antiemebics? I'd say when the eye is completely uninflamed and the patient's not taking steroid, if steroid has been used. Monotherapy is successful in most. I'll give you data in a moment. Steroid in acanthamoebic keratitis, very helpful if there is intraocular or limbal or scleral inflammation of significance. So in Europe, generally, clinicians will give steroid in those clinical circumstances. In North America, they are not used. And I think that question does need to be resolved. We believe steroids are helpful, and I use them readily if there is inflammation which justifies that. For those patients with scleritis, as with scleritis from any cause, you need systemic immunosuppression to control the scleral inflammation and the symptoms resulting from the scleral inflammation. Now, in which patients would you expect, and can your patient expect, to have successful medical treatment without recourse to surgery? The first thing is early presentation. Certainly if a patient presents with symptoms of duration 2 weeks or less, they should get a very good response. They don't all, but you'd expect them to. Steroid should not be given in these earliest weeks. As in so many causes of infectious keratitis, hold off on steroid. In this disease, as much as in any. In those patients with what we would term unresponsive disease on medical treatment, a common scenario is a patient with continuing symptoms, continuing inflammation, and you need to resolve the question: is this due to resistance of persisting amoeba, or is this due to inflammation in an eye in which there are no more surviving amoeba? You already have cure of the amoebic infection. And the strategy there is to take a corneal biopsy and culture. If the culture is negative, that tells you you've got amoebic medical cure and the treatment needs to be directed at the secondary inflammation. If the culture is positive, that tells you you've got uncontrolled amoebic infection and your treatment is going to be more difficult because you've already been treating with anti-amoebic agents without success. And they are very, very difficult patients in which to get disease control. So these patients in whom there are problems and in which you've got to look at alternative treatments tend to be those with deep disease, deep corneal disease, possibly extending into the sclera, which is a bad prognostic sign, as in any keratitis, and those patients with late presentation, who usually do have deep disease. And in those patients, other than biopsy, you're looking at possibly needing a tectonic keratoplasty or an excisional keratoplasty to get disease control, in the hope that you do not have immediate recurrent acanthamoeba infection post-keratoplasty. And that's the big problem. Audit of cases. These are Moorfields data from 3 years ago, 196 cases, medical cure in the majority of patients, 36% scleritis, secondary bacterial infection. Look at the high figures, 18%, 11% corneal perforation. These are not very good results, and in a center where we have a lot of experience. Median duration of treatment, 6 months. So tell every patient in whom you make a diagnosis of amoebic keratitis, you could have an extremely long treatment course. I tell them all, and I tell them they may lose vision. Better to tell that to the patient initially, not tell them when they're complaining 5, 7 months, 9 months down the track that they never realized they had such severe disease. Good vision in more than half the patients, bad vision 17% in this large group. So the prognostic factors for good outcome, I've told you, early presentation, short duration of symptoms prior to establishing the diagnosis, and avoidance of steroid prior to 2 to 3 weeks at least post-diagnosis. The most recent clinical trial is of polyhexanide 0.8% versus polyhexanide 0.02% combined with propamidine, which is Brolene. There was no difference between the two groups, and the medical cure rate was about high 80s%. Generally good results and equivalent in both treatment arms. Just be aware that nobody anywhere has done a dose response curve of PHMB. That agent was first used at that dose of 0.2% without any evidence that that was the best dose or the best concentration. That's not the way we approach antimicrobial chemotherapy usually, and that was just based on patient comfort. So I think a lot more needs to be done on therapeutics, including looking at alternatives. And I just want to finish with this. This is from India, bottom half of this slide, miltevosine, an anti-leishmaniasis drug, 5 patients treated, extremely poor results. But I commend the investigators, it was in LV Prasad here in India, because at least they're doing some kind of analysis of the pathogens and making a rational choice and looking at new agents, which I think we need to be doing in more big centers. So this was not a successful introduction into the armamentarium, but I'm hoping it will be followed by more. So to conclude, include acanthamoeba in the differential diagnosis of any chronic stromal keratitis, especially in a contact lens wearer. Be particularly aware of assumed non-resolving HSV. Be aware of the diverse early appearances of disease, untreated scleritis, superinfection with other pathogens, and always inform patients about a possibly very severe disease course. Thank you. I hope you find that helpful.
Thank you, Frank. Unfortunately, we've overrun our session. We have no time for discussion. We thought we would have about 18 minutes or 15 minutes at the end for discussion, but it's 4:30 and I think the next session is going to start. So thank you all for attending, and thank you very much to all the speakers for being here. Oh yeah, all the speakers, could you collect here for a photograph, please. And they have to sign that form? No.